Hello and welcome to Everyday Medicine. I'm Dr. Luke, and I'd like to thank you for joining me on this podcast series where we share conversations with colleagues exploring their special interests in medicine and bringing insights, ideas and advice which I hope will be helpful for your medical practice. In this episode, we're talking with an expert on hyperbaric oxygen therapy, HBOT. Or for Australian audiences, listening gives eligibility for your CPD, so log in and add this as an activity. You may also consider journaling, reflection, and adding to the review and performance section in your CPD. Well, on a recent vacation to Exmouth on Western Australia's far north coast region and home to the amazing Ningaloo National Park, I had the pleasure of meeting anaesthetist and outdoor adventurer Dr Neil Banham. I discovered that when Neil wasn't kiteboarding, his daytime job was spent as the Director of Hyperbaric Medicine at Fiona Stanley Hospital in Perth. Well, our conversation about his work exposed my deep ignorance of the potential uses of HBOT beyond the management of air and gas embolism, and it piqued my interest to understand the various conditions that may be assisted by this treatment. Hyperbaric oxygen treatment exposes an individual to near 100% oxygen while inside a treatment chamber at a pressure higher than sea level pressure. For clinical purposes, the pressure must equal or exceed 1.4 atmospheres absolute. Most HBOT in Australasia is performed at 2 atmospheres. HBOT was first used in the early 20th century and then again by the US Navy in the 1940s to treat decompression sickness, the bends. It was used in the 1960s to treat carbon monoxide poisoning, and gradually its use and indications have been expanded. There are currently 15 approved indications accepted by the Undersea and Hyperbaric Medical Society, and these fall under both urgent and non-urgent conditions. The Medicare benefit schedule has specific item numbers for HBOT covering many of these. Well, the urgent conditions include air embolism, central retinal artery occlusion, carbon monoxide poisoning, clostridial myonecrosis, that's gas gangrene, compromised surgical grafts and flaps, crush injuries, compartment syndromes, and acute arterial insufficiency, decompression sickness, intracranial abscess, necrotizing soft tissue infections, exceptional blood loss, anemia, specific acute thermal burns, and idiopathic sudden sensorineural hearing loss. Non-urgent conditions include delayed radiation injuries for soft tissue or osteoradionecrosis, and HBOT for radiation cystitis has also been shown to be effective in over 80% of cases in the published literature. The usual course of treatment for this indication is 30 sessions, 2.5 hours per day for 5 days a week, for 6 weeks in a row, and that certainly is quite a significant time commitment. HBOT is also indicated for radiation proctitis, chronic refractory osteomyelitis, and for some problematic wounds such as grade 3 for diabetic foot ulcers. There's been significant interest also in its application in inflammatory bowel disease, including both for treatment of ulcerative colitis and Crohn's disease. In a recent systematic review and meta-analysis of 118 patients treated with HBOT for perianal visualizing Crohn's demonstrated clinical response and remission rates of 75% and 55% respectively, which is very interesting and warrants enlightened consideration. Several studies have also demonstrated significant improvements utilising this therapy as an adjunctive treatment for hospitalised ulcerative colitis flares, and its place in this management will be watched with great interest. Well, some of the contraindications for HBOT include untreated pneumothorax, uncontrolled hypertension, congestive cardiac failure with an ejection fraction below 35%, claustrophobia, congenital spherocytosis, uncontrolled diabetes, chronic sinus conditions, and advanced emphysema, that is the blue bloater. Other more esoteric factors also exist, such as avoiding dalsulfuron, which blocks superoxide dismutase, and doxorubicin. Well, as with every field of medicine, delving into specialty subjects highlights a wealth, deep knowledge and expertise. With my curiosity at a high, I was privileged to hold this conversation with Neil, which we discussed some of the practical issues associated with HBOT, how it works, highlighting the value of it and many of its indications. And there's plenty to learn from this and to think about in relation to some of the clinical problems we are tasked to manage. Please welcome Neil to the podcast. Dr. Neil Banham, thank you for joining me on Everyday Medicine to talk about hyperbaric oxygen therapy. I really appreciate you making the time, Neil, and also appreciate meeting you in a very exciting location at Exmouth, where you were kiteboarding and running over turtles and having a wonderful time. So it was very nice to meet you there with all the other friends and so forth. And while we were there, we got talking about your career and hyperbaric oxygen therapy. And I'm very glad that we can just explore the applications of it a little bit further with you today. Can you give us a little journey, run through your journey in medicine? Give us a thumbnail sketch, Neil. How have you got into this part of medical practice?
Thanks, Luke, for asking me to participate. So I'm an emergency physician by trade, and I studied medicine at University of Western Australia. And after my junior years, resident medical officer years, I was after a registrar job where I had days off during the week. So that took out general medicine and medical specialties, because we used to be really into barefoot water skiing, and that was the time of the week where no one else was on the water. So
the barefoot water skiing took priority.
So that's how I got in, and it's sort of a bit like the house of God. So I asked the boss at the time, and he said, "Oh, I'll give you a job as long as you do the primary." And anyway, so I did the primary, passed the primary, got my fellowship, and then there was a fellowship year where I did half-time hyperbaric at the newly opened Fremantle Hospital unit and half-time emergency medicine at one of the peripheral hospitals. So that was back in the day, as they would say, back in 1991, and sort of had an association ongoing with the hyperbaric unit at Fremantle since, doing some on-call, some shift coverage, and a little bit of research. And then when the incumbent director retired, I got headhunted for the role because Professor Simon Mitchell, who's the editor of Diving and Hyperbaric Medicine and quite a famous researcher and presenter on diving medicine, decided he didn't want to come, so they got me instead. And I've been there really since 2009 at Fremantle, and then at Fiona Stanley Hospital when we moved to a brand new hospital from the end of 2014. So I've been there 10 years now.
Well, that's a lot of experience. Well, thank you for taking us through that. Now, Neil, what is it? Just tell us a little bit about what hyperbaric oxygen therapy is and how it works.
So hyperbaric oxygen is where a patient is given 100% oxygen under pressure, usually at pressures, defined as pressures over 1.4 atmospheres, but clinical hyperbaric medicine, we use pressures in the range of 2 to 2.8 atmospheres of pressure. So that gives you a very, very high dissolved oxygen content in your plasma, as well as full of saturating your hemoglobin. And we can't go to pressures higher than that because of the risks of oxygen toxicity, particularly seizures above 3 atmospheres absolute of 100% oxygen. So as well as the obvious effects of the increased oxygen giving you increasing diffusion distance and reducing hypoxia in hypoxic tissues, it has other effects. So by Boyle's law, the increasing pressure will decrease the size of gas bubbles. So that's one of the ways that it treats decompression sickness and gas embolism, whether that be diving related or iatrogenic, but also other rare forms where there's gas in gas gangrene or necrotizing fasciitis. It helps deal with the gas there, and also with where there's gas around the bowel, which we occasionally use that for us pneumatosis coli occasionally as well, and with good effect. As well as the reducing ischemia and crushing bubbles, it has an anti-inflammatory effect by inhibiting margination of white cells in capillary beds via ICAM, and also stimulates angiogenesis in tissues where there isn't a lot of capillaries, such as previously irradiated tissue, by episodic pulsing of 100% oxygen. So it sort of converts really a chronic wound into an acute wound where new capillaries are stimulated to grow. And that's the main effect in soft tissue radiation type injuries such as radiation cystitis, radiation proctitis, but osteoradionecrosis, soft tissue radiation wounds of the skin, breast, chest wall, arm, leg for sarcomas. Those wounds typically don't heal. Even when they're grafted, they break down again. And there's quite a good success rate with treating these wounds with hyperbaric oxygen for 30 or 40 sessions and achieving primary closure, or around sometimes it will allow, if primary closure doesn't happen, which in my experience is, depending on where it is, but often it will close, allows a graft or a flap to be successful. So they're the main mechanisms.
No, it's quite, that's very helpful to understand. There's quite a few sessions, up to 30 sessions. Are you able to do more than one session a week?
So I'll talk about, say, radiation cystitis, which there aren't a lot of other treatments for, and the other treatments that are out there, such as instilling alum or other nasty chemicals in the bladder, are not good, and cystectomy's got 30-40% mortality rate associated with it. So there are really no other good treatments at the moment that seem to be permanent radiation cystitis. But we treat those patients for 30 to 40 sessions, 5 days a week. So that's 6 to 8 weeks. And that's about 2.5 hours. And we do that at 2.4 atmospheres absolute, or 243 kilopascals, or the equivalent of being underwater at 14 metres of seawater. So we've got 2 types of chambers. One's a big room-like chamber where 6 patients and an inside attendant who's a nurse can sit down and they can take in reading material or also watch TV. And that chamber is compressed with air, and they breathe oxygen either via a head hood or via a tight-fitting mask. And the other chambers which we have 2 of, monoplace or single-person chambers, where the patient usually breathes 100% oxygen, and they can't take anything into the chamber that might be combustible because of the fire risk. So they can watch TV or sleep or meditate or relax. And again, those sessions for just over 2 hours. So it is a significant undertaking. The way I say it to the patient for radiation cystitis is, you had 30 or 35 fractions of radiotherapy.
Yeah.
This is much the same, except it takes longer, but you don't have to have a full bladder when you go in, which is probably the most uncomfortable thing about having radiotherapy, is you've got to go in with an empty full bladder.
It's quite a commitment, but it seems like there's a lot of upside. Is it widely sort of accepted amongst practitioners in Perth? Here you've got access to it, and you've got quite a few chambers there. My feeling is, or my sense is, that it hasn't been perhaps completely appreciated for what it may offer in medical practice around Australia, where access is often difficult. Is it being widely referred to? Are you now finding that you've got very long lists of patients that are needing these sorts of treatments, and access is actually the issue? Or how's it be taken up by the general?
Well, certainly we're busy, and we run pretty close to full a lot of the time. We only treat accepted indications, either Medicare accepted indications or the list, which is published by the Australian and New Zealand Hyperbaric Medicine Group, which is very similar to the Underwater Hyperbaric Medical Society in the US, of conditions where it's shown to be a benefit by evidence-based practice. So we don't treat unestablished indications, and we don't do it for profit. So we can afford to turn away patients that we don't think are going to benefit, because we don't see that the indication is there.
But one of the treatments is for that central arterial retinal artery occlusion. That would be a very important condition to treat if you can access the chamber quickly. Is there a time frame whereby if a patient accesses the chamber, you get a good success? Tell us about the parameters there.
Yeah, so we recently published a paper about that, about the experience Australia-wide and how they do it. But most chambers would want their cases to be under pressure within 8 hours, 12 hours max.
Yeah.
And we would definitely usually not treat after 12 hours, because the lesser likelihood of success, and definitely not after 24 hours, unless the patient was blind in the other eye, then we may consider it. And there are case reports of delayed efficacy of retinal artery occlusion, but in our experience, the sooner that you get patients, the better their results are. And we find probably not everyone, unfortunately, responds in that condition, but probably 40 to 50% will get meaningful improvement in their vision.
What's the mechanism there, Neil? How's it working in that pathology?
So retinal artery occlusion really is just a mini stroke of the ophthalmic artery, which supplies the retina, the end artery to the retina, and it really is just allowing oxygen to diffuse across longer distances to maintain
I see. Yeah.
the retina until
tissue viability.
the blood vessel recanalizes.
I see. Okay, that's interesting. There are conditions that we've probably discussed that might be of interest, like inflammatory bowel disease, that would not be on the list of perhaps widely accepted protocols at this stage. Do you have any comments about that treatment of people with ulcerative colitis and Crohn's disease, difficult fistulas, and they're often very difficult patients to manage, some of these cases?
Yeah, we've had very good results, particularly in patients with fistulating Crohn's disease who are on the MIBs, MABs, or MUBs, whichever ones, usually infliximab, but might be on two or maybe more, whatever's flavour of the month or is being researched. But they're on that, and they have 10 or 20 sessions with us, usually, but not always. I'll have seat and drains in place, and at that stage, the seat and drains get removed, surgeon roughens up the tract, and we give another 10 sessions.
Okay.
And they do have a high success rate, and they don't seem to relapse. So we have seen one girl, I think in her 20s, who came back with recurrence of fistula after a couple of years, which again we healed. But they're very debilitating type wounds. They're really hard to heal.
They can be extremely hard, and I have a few patients like this that I have in mind. Am I right, though, that this is not received? This is not one of the indications that's been added to the list by the hyperbaric group at this stage. Is that
it's on the UHM list, and it's one that we use. And the other one that's interesting is the use in fulminating ulcerative colitis, where the options are colectomy, and it's also got a significant mortality rate as well. So there's been some phase 2 studies showing that if you give 5 days of hyperbaric in addition to the infliximab or whatever other things the gastroenterologists are using at the time, it reduces significantly the rate of colectomy and hence avoids mortality. So we've been doing a couple of those, and we were starting up a trial, a clinical randomized trial for that. But the problem is they're so few and far between. It's actually quite hard to enrol them. But usually they're in hospital for the week of their flare, and hyperbaric is part of their course of treatment for that.
I think that is something I would watch with very great interest. Tell us a little bit about chronic wounds, that maybe osteomyelitis and the like. That do you have any referrals for those sorts of cases, and what's your success like in that regard?
So we get several types of wounds. So diabetic foot ulcers is quite common, either to heal them, prevent amputation, or minimise the level of amputation on those. But for that to be successful, they need to have good plumbing. So they need to have good vessel supply to the affected area, and we're just really overcoming the microvascular problem rather than the maculovascular problem. And that's also really the case in peripheral vascular disease with arterial ulcers that don't heal. So we're fairly choosy on the ones that we accept, because we have a fair idea of which ones are probably going to need to go to amputation, whatever you do.
Yes.
But some of these will say, well, if you do a distal amputation, say a forefoot rather than a below knee, and then we can give them 5 or 10 sessions of hyperbaric afterwards, and with a good likelihood of it healing. So we deal very closely with the multidisciplinary foot unit at our hospital and at other Perth hospitals, and I think that's similar around Australia. There's a hyperbaric unit, a public hyperbaric unit in each of the capital cities in in Australia, as well as there's also one in Townsville, and as well as a public hyperbaric facility at the Royal Brisbane Hospital in Queensland. There's also the Wesley private hyperbaric facility in Brisbane as well. And the focus on their stuff is wound care rather than acute conditions. So they don't treat many divers. They don't treat ICU type cases. Whereas the Alfred in Melbourne does a lot of ICU cases. So they do a lot of necrotizing fasciitis, and also they do a lot of crush injury, of lower limb crush injury, so Gustilo 3 type nasty wounds of lower limbs where there's loss of tissue, devitalised tissue, and broken bones that have been fixed and a big deficit. So they were part of a randomised controlled trial that showed a very good outcome with the low number needed to treat of limb sparing with that protocol. And obviously it's associated with surgery and antibiotics and debridement, et cetera, but the only additional intervention was hyperbaric.
It's very interesting. I'll come to discussing the future with you in a moment, because I feel like we need to get the word out a bit more about this maybe. But just contraindications, what are the main concerns you have? If someone has a pacemaker or if they have contact lenses, obvious lung issues, just run through the contraindications we should be aware of.
So most pacemakers that have been put in the last 10 years, or most implantable devices, are hyperbaric safe.
Right.
So pacemakers, defibrillators, cochlear implant devices, they're all pressure safe. Just need to take off the external receiver for the cochlear implant type patients. So implanted devices usually aren't a contraindication unless the patient's got quite an old device. And if that's the case, then we talk to the cardiologist about what's likely to happen should the pacemaker be damaged and not work, and whether that's going to create a big problem or not. And if that's the case, and they still do need hyperbaric, then it may be that the pacemaker will need to be changed. But that's a very rare thing.
Yeah.
So the commonest contraindication we have is patients are claustrophobic, so they don't like wearing the head hood or they don't like being closed, but some that like the big chamber, the big room chamber, won't go in the single person chamber, but others don't like the head hood and will go in the single person chamber. So most often some people will go in that.
You need mirrors on the wall, Neil.
Yeah. Well, they're actually quite big, and they're like aquariums, so you can, they've got a big perspex acrylic tube, so you can see out. It's just the ends that are metal.
Yes.
So you can see out. You can watch TV through the glass.
Let's see. Yeah.
But lung disease probably is the main one that we worry about because of the risk of pulmonary barotrauma and gas embolism. So if people have got significant bullous lung disease from previous smoking, we're fairly cautious, and it really depends on the risk benefit, like everything else in medicine. But if the benefit is not really high, we would probably decline those patients. So because our decompression rates are so slow, usually gas trapping's not such an issue. Contact lenses are fine. The diabetes is fine, but some patients with treatment drop their blood pressure, so we usually monitor that.
Do they complain about ear popping? Is that a significant issue, or is it something that they have to be learned, that has to be taught to them? Valsalva.
So middle ear barotraumas or middle or eardrum injury is the commonest complication, but usually that's minor. Most patients can be taught to clear their ears sometimes with the aid of topical decongestants such as Drexine or pseudoephedrine as well in the early stages. And for those where they still can't clear their ears, then we would get grommets done, so myrigotomy tubes put in by our ENT colleagues, and that solves that problem.
Yeah, I see. There's certainly
that's probably 5% of our caseload, I would guess.
Neil,
so there's no untreated pneumothorax is quoted as an absolute contraindication, but that's pretty rare.
Yeah.
And if you have a multiplace chamber where someone can go in with an ultrasound machine and look for it and treat it should it occur
Yes.
or get bigger, then it's probably less of a contraindication. So it's not absolute anymore. There are no absolute contraindications. We don't like violent patients or psychotic patients in our practice, probably as much as you don't like them in yours. So we would.
At least you've got them locked up in the chamber.
Yeah. So we think about the safety of our inside staff as well. So that's another issue that we would consider.
Yes.
And that might be for treatment of carbon monoxide poisoning patients.
I see. Yes.
They're the sort of ones that might be a risk. So we're fairly careful about whom goes in the chamber with them.
Yes, got you. My impression, Neil, is perhaps arising from my own ignorance, is that maybe clinicians in bigger hospitals where there are chambers have a fairly good idea about referral, but that a lot of us in more peripheral sort of locations perhaps aren't thinking enough about what hyperbaric oxygen can offer. Would you agree with that? Do you see there's a future that's expanding now that we're getting better knowledge and understanding about what can be treated and what benefits can be given to patients from this?
I think so, and our unit and most others around Australia have got a fairly strong research base, and so the indications that we treat are getting stronger evidence for that, and if indications with research where the evidence isn't there, then we would stop treating that. But there's not really any of those at the moment, though some people talk about prophylaxis for osteoarthritis necrosis with hyperbaric being less important than perhaps it used to be because of the newer surgical techniques and more judicious use of radiation. But we still see lots, so it's still happening.
Well, so tell us what do you see as the future for this sort of treatment? Do you see more hyperbaric oxygen chambers maybe being installed and built, and a bigger take up of what it has to offer?
Yeah, well, I suppose you need to look at areas where there's a big market, and long COVID, there are a few studies of that. Probably not that convincing, and there are some methodological flaws in the small randomised study that was done. We've done one or two for other indications who have had long COVID who have improved benefit. We've also had a few cases of complex regional pain syndrome that have responded, but also some that have been treated for other indications that haven't, which erectile dysfunction. There's a study out of Israel showing that it's helpful for that, and there's we sort of looked at doing a study in our unit on erectile function in patients before and after their course of hyperbaric therapy for something else to see if they have noticed a difference. I mean, there is a big placebo effect for hyperbaric, just the effect of going in the chamber, and whether or not chronic neurological conditions can be reversed, because some of the believers say that there is ischemic areas in the brain that can be remodeled and fixed, which I'm not. Because one of the other effects of hyperbaric is to mobilise stem cells, but I'm not really a believer in that. And I think a lot of that is a participation type effect. But the US military spent a lot of dollars on big trials in the US looking to see if hyperbaric was the magic bullet for all their post-concussion traumatic brain injury type cases that were coming back from combat zones. And what they found is that mostly is that all the participants in the studies improved, whether or not they had the sham treatment or the real treatment. So that was sort of a Hawthorne type effect. You watch someone, or a participation type effect.
Yes.
They get order in the life. They're coming for 30 or 40 sessions every day. It gives them purpose, and therefore they start to feel better anyway.
And attention. It is used for sensorineural hearing loss too, isn't it? It's something we hadn't spoken about. But there are patients who develop that. I've had one of my own patients, and without any obvious reason. And
It's becoming more diagnosed. Whether it's more common or not is difficult to say. But
shingles could be a social
because there's a hearing testing centre at every shopping centre.
Yes.
A hearing test now is readily available, whereas 5 or 10 years ago it wasn't. So we've seen an exponential growth in our cases referred to us.
They've got to be fairly acute, though, don't they, Neil? Is that right?
Yeah, we would treat them within 2 weeks of onset, and the sooner the better. And it works better for low frequency loss than high frequency loss. And we would only consider treating them later than that if they were also deaf in the other ear. But the cases where they're also deaf in the other ear tend to present earlier rather than later in our experience, because it's not just a blocked ear; it means they can't hear at all. So
they're very aware of the change.
We get if they come early and they're treated with steroids within 24 hours and come to us within 3 to 5 days. Most of them do very well. It's the ones that there's a delay. They go to see a practitioner and says, "Oh, you've got a blocked ear. I'll give you some decongestant, some amoxicil, and we'll see what happens." And up to 5 days on the amoxicil, nothing happens, and they go back and then they have their hearing tests, and it's a sensorineural hearing loss rather than a middle ear problem. And maybe if everyone was trained again how to do a Rinder's test to differentiate between sensorineural and conductive hearing loss, then that problem would be averted.
It's a long time since I've done that, Neil.
Yeah. But
Neil,
pretty simple.
I really appreciate you taking us through this, really good introduction and overview, actually, of hyperbaric oxygen therapy. And I think we probably as practitioners need to be more aware of what it has to offer, and to think about it as perhaps part of our, management sort of strategy for a lot of patients.
And referral's pretty easy, but unfortunately it's all capital city centric.
Yes.
Townsville, but if there is a condition where you think it might be reasonable, all of the hyperbaric facilities are happy to receive phone calls, during office hours, unless it's an emergency, and we'll see your referrals.
Neil, thank you. I know you're a very keen kiteboarder, Neil. You're a waterman. Tell me, the wind in Perth, what's it like? I know you're going to be out there tomorrow.
No, I've got to work tomorrow, but I was out yesterday and today, and it's going to be windy again on Saturday. So it's 20 to 22 knots today and 20 to 25 yesterday. So
but we'll see you right on this island.
This time of year.
Well, look.
This time of year is windy.
Neil, thank you. I hope you get a good respite over the Christmas and New Year period too, and really appreciate you making the time to.
Okay, thanks for asking me, Luke. Cheers.
Thank you very much. Well, thank you for joining me with Neil Banham on the topic of hyperbaric oxygen therapy. I hope you've learned as much about this as I have. Certainly now considering expanding my use of this treatment, and particularly in inflammatory bowel disease. I do thank Neil for his time and expertise. During the podcast series, we will be covering a wide range of topics across many specialty interests. The discussions aren't intended as specific medical advice for patients, but as general information only, and reflect the opinions of the guests interviewed. I do hope you can join us with our next guest. Requests for new topics to be reviewed and comments about the conversation you've listened to are welcomed, and maybe email to manager@jailhealth.com.au.